thank you for having us here today. I always love to talk about the retina and cerebral malaria. And I'm going to give you a bit of an update. I don't know how many of you are aware of the fact that there are retinal findings in cerebral malaria, which are actually rather important, I think. But I'm going to try to, I may have talked about this in the past here at UBC, but I'm going to try to give an update anyway. I guess okay. Before I start, I want to acknowledge many people who have made this work possible, because what I'm going to describe to you today actually has taken place over more than 25 years. And several of these people are actually from UBC. Their names are underlined up there, and I forgot to put Peter Nash's name on there, and I see him glowering in the back. So Peter was also involved in this, and we couldn't have done this work without lots of people. So why is malaria important? Well, there's still 200 to 500 million cases a year, and it kills over 1 million people a year. Most of those are children in sub-Saharan Africa. That's where 90% of the deaths take place. Economically, it's estimated it costs about $2 billion a year to the burden for malaria to the African economy. Only Plasmodium falciparum causes life-threatening infection. There's other Plasmodium that cause different types of malaria, but it's only the P. falciparum that causes the life-threatening infection. And the way it does this is it invades red cells, and they become sticky and adhere to the walls of the vessels, especially in the brain. So cerebral malaria is actually quite difficult, or can be difficult to diagnose. Cerebral malaria is the most severe syndrome of malaria, and the diagnosis is difficult because the clinical features of cerebral malaria are really variable, and they're nonspecific: fever, lethargy. So there's a broad differential diagnosis. And other diseases, of course, can coexist with malaria. And what really makes this difficult is that in endemic areas, at any time, if you went through and measured, 25 to 75% of the population might have asymptomatic infection. So a kid becomes comatose, goes into the hospital, they see he has malaria parasites, and it's assumed to be cerebral malaria, and it isn't necessarily. So before I talk to you about what's new in cerebral malaria retinopathy, I think I better review what's old in malaria retinopathy in case you've missed out on this information. We lived in Malawi from 1990 to 94, and one night I was having dinner with Dr. Terry Taylor, who runs a really first-class research project on malaria. And I asked her about cerebral malaria, and she was telling me about it. And I said, what do you see if you look in the fundus of these kids, the ocular fundus, of course? And she said, well, nothing much. And I sort of cynically thought, well, yeah, that's what internists usually see when they try to look at the fundus. So I said, could I look? Would you mind if I came in? I'll bring my indirect ophthalmoscope and I'll take a look and see what's in there. So I started going in and seeing these patients, these comatose kids, and I was absolutely gobsmacked at what I found in the fundus. And it hadn't ever been described before, so I wasn't sure what the heck I was looking at. So I'm going to run through, well, this is 25, almost 30 years later. What we've done in these years is we've documented the findings, and this was very difficult because this started before there were such things as digital cameras. So getting photographs of this was really a challenge. We've described the histopathologic correlates of the findings, demonstrated their clinical significance, and now what we still have to work hard on is changing the thinking of malaria researchers to use these findings effectively in their projects. So running through what we find in the retina, is there a pointer up here? Oh, okay. So the first finding is these white-centered hemorrhages, which are really common. About 60% of kids will have these. Second thing is what we call retinal whitening. If you look at this sort of fluffy appearance, this is perifoveal, and this is a mild case. There's also a hemorrhage in there, but ignore that. And we just call this whitening. But it can occur in a wide spectrum of severity. Here's a severe case where you see a lot of this whitening around the fovea, and it's always in a mosaic sort of pattern. It disappears completely if the child survives and wakes up. Here it is in the periphery. It's not always in the macular area. You can see it outside the macula, and you can see those white sort of mosaic pattern there. Here it is where the whitening has actually coalesced in some spots. So that's a severe case of it. Sometimes all you have is one little point of it. So what is it? Well, over the years, the team managed to get fluorescein angiograms done. And so here's the fluorescein that goes along with this, and you can see what it is. This is areas of capillary dropout and hypoxic retina. So it causes this white opacification, which disappears completely, as I said, with no visual sequelae that we've ever been able to demonstrate if the child survives and wakes up, and then we can measure it later. And of course, the same process is going on in the brain. So then the second finding, or the third finding, is these abnormal vessels, and that's all we call them still, is abnormal vessels or discolored vessels. And you can see how bizarre this looks, kind of a funny lamellar sort of flow pattern looking in this vessel, kind of orange. Here's another one. This vessel's relatively normal, and then all of a sudden it turns chalk white. And you can also see the capillary bed is delineated. So this is very bizarre. There's nothing else that looks like this. I thought I was losing my mind when I was seeing it in these kids all the time, because there were no descriptions of it at the time. Here's another one. This is odd. You get white along the edge of the vessel, and you can also see, here's white vessel, and again, the capillary bed is somewhat delineated. Here's another one, very strange. I wasn't even paying attention to the hemorrhages anymore. I was so fascinated by vessels that look like this. And these vessels here are sort of orange when they shouldn't be. Here's another one. The abnormalities often just occur in segments of the vessel. Here it is red, and yet here it is white. So what is this? Now, this is work that Val White did when I managed to get the eyes of these kids and bring them back. And this is a lovely flat mount that Val made, and then did a stain for hemoglobin. And what you can see here is all those little brown dots, by the way, are the malaria parasites. Malaria parasites eat the hemoglobin in the red cells. So what you have here, for example, is a bunch of malaria parasites in this segment, but almost no hemoglobin. Here next to it is a segment that's relatively well hemoglobinized. Here there's hemoglobin along in the central core of the vessel, but along the edges of the vessel, where, remember I said that the parasitized red cells tend to stick, there's relatively less hemoglobin. So I think that is a very good explanation for why you could get a vessel looking like this, because it's, of course, the red column of hemoglobin that makes the vessels look the way they do normally. Here's another one of Val's nice stains, and you can see here a central core of well hemoglobinized red cells which are not parasitized. And then around the periphery, you've got these late stage schizonts which have devoured all the hemoglobin. And again, I think that is a vessel like that's a good explanation for this kind of clinical picture. So that was really satisfying to me, to be able to finally figure out what it was that we were looking at. In terms of the clinical significance of this, that required that we develop a grading scale for the severity, because each of these signs, the hemorrhages, the whitening, and the abnormal vessels, can occur in a wide spectrum of severity. So we developed a grading scale for each of the features of the malaria retinopathy. And we're able to show that the retinal signs were associated with the risk of death. Now, when we could do this, then the malaria researchers actually started believing me, because I don't think none of them could see what I was seeing. There weren't any other ophthalmologists in Malawi at that time. But being able to show that these were associated with death was very important. Furthermore, the more severe each of these signs was, the higher is the risk of death in the children. And the retinal signs are also associated with some specific clinical and laboratory indicators like hematocrit and platelets. So if we look at the case fatality rates, and this is a group of children, all of whom would have been said to have cerebral malaria by the pediatricians and the internists. They're all comatose, they've all got parasites and are thought not to have any other causes of their coma. But if we divide them up according to their fundus signs, the kids with a normal fundus had a 7% fatality rate. This is over 15 years that we collected this data. So we had 900 children with cerebral malaria in this study. The children with malaria retinopathy that did not include papilledema, because some of the kids with malaria retinopathy also have papilledema, their case fatality rate 15%, 36% for the group that has malaria retinopathy with papilledema. And I think you can imagine how, if that retinal whitening is caused by hypoxia and swelling, and that same process is going on in the brain, the kids with the worst retinal whitening are the ones who get the papilledema. That makes sense because the same process in the brain is leading to the papilledema. And then finally, there's this group, which is really a small group, but they have papilledema alone, and they have the highest case fatality rate of all. So the way I understand this is that in this group of children, all of whom supposedly have cerebral malaria, we have a group which I call Group R, retinopathy positive, who have hemorrhages, abnormal vessels, and retinal whitening, plus or minus papilledema. Their mortality rate's about 19% overall. And when we've been able to do autopsies on these children, indeed, we find cerebral sequestration of the parasitized red cells, hemorrhages, and fibrin thrombi, which is what's causing those white-centered hemorrhages in the retina. They have a coagulopathy going on and local areas of tissue hypoxia, secondary to hypoperfusion and anemia. Group N, as I call them, the group that are retinopathy negative, most of those kids actually survive and wake up very quickly, and we think maybe they have I'm going to say mild case of cerebral malaria, or maybe it's just a prolonged postictal state. And they are being treated for malaria, but they invariably will do very well. Although there are 7% of those who die, as I said. Now, amongst those 7% with a normal fundus who die, of the ones we've been able to autopsy, they have always had a different cause of death. It wasn't malaria at all that was causing them to have coma. They had incidental parasitemia. And what we've actually learned from the autopsy study is amongst children who die with cerebral malaria, about 25% of them don't have cerebral malaria when we can autopsy them. And that 25% can be identified because of the fundus signs. They should have been, if the fundus signs had been looked for and people had realized this wasn't cerebral malaria, perhaps they could have treated these children for something else because it wasn't cerebral malaria. The final group, Group P, which is just papilledema's false cerebral malaria 2, they don't have any malaria retinopathy. The mortality is very high in this group. It's a small group, as I said, and they have multiple pathologies. When we've autopsied these children, they also have no sequestration of parasitized red cells, just a bunch of different causes of death in these kids. Incidental parasitemia. So to summarize that, children with clinical cerebral malaria are actually a heterogeneous group, and they're best differentiated by looking at the fundus. Now, this is important because older studies of both treatment and pathophysiology of cerebral malaria didn't take this into account, and there's been a lot of conflicting and unreproducible results. now requiring fundus signs as a criteria for a case definition allowed the team in 2015 to demonstrate that brain swelling is actually the key predictor of death in cerebral malaria. This is important because 25 or 30 years ago, there was a big study in Kenya that when they assumed brain swelling was the problem, and they were trying to treat it, and they had terrible results, and they quit doing it anymore. But that's because they probably had a group of kids with a whole lot of different pathologies in their study. So right now in Malawi, the current research is going on is focusing on treating brain swelling, but this time we're only treating the kids who really have cerebral malaria. So a big question for me has always been, how are we going to ensure that these fundus signs are used for accurate diagnosis when we don't have ophthalmologists in malaria research projects? And our experience is trying to teach the non-ophthalmologists to examine the fundus have really been very discouraging indeed. So what are we going to do about that? This is the what's new part. A small group in Albuquerque, New Mexico, has developed an algorithm now that can, with high quality photographs, specificity of 100%, sensitivity of 95% at identifying malaria retinopathy using photographs. So their first studies, well, this is an example of what their algorithm, here's a case with all the findings, and their algorithm will make a picture like this. I didn't think they'd be able to do this because even when you're examining these kids clinically, it can be hard to tell the whitening from the just reflections off the internal limiting membrane. I was amazed that they could do this with a computer and be as accurate as they were, but they have done it. It's a pretty impressive algorithm. Their first work was with a Topcon desktop camera, which is of course really expensive and had to be modified in all sorts of ways in order to accommodate a comatose child. Last year, they managed to do this using the Picture Plus portable camera with the software. They get the picture of the fundus, and then it transmits the images to a tablet, and the software's in there, and it can generate a patient record and say whether there's malaria retinopathy or not. And this next year, they'll be working using the InView camera, which can work with an Apple or whatever, iPhone. So they'll be integrating the software into the iPhone, because this InView camera is now around $1,000 or so. So that makes this possible to use in research projects in sub-Saharan Africa. So take-home message here. Malaria retinopathy is a unique entity. Consists of the 3 retinal signs that we've looked at. It's the best way to accurately diagnose cerebral malaria and the best predictor actually of outcome in patients with cerebral malaria. The new imaging techniques that are coming on will allow non-ophthalmologists now to identify it and ought to enhance research that's still being done to try to understand cerebral malaria and find better treatments for it. So that's it. Thank you.
Thank you very much, Susan, for an enlightening lecture. I don't think many of us know very much about retinopathy in malaria. And once again, you know, the Lewallen Courtright team has come up with some brilliant lateral thinking to try and improve the management of these serious diseases in desperate countries. So I'd just like to introduce Paul Courtright with his extensive CV and wonderful work throughout his career. And he also is a game changer, and when was previously synonymous with trachoma was synonymous with world blindness. And now we've got some new things to know about what's happening on the globally with the trachoma control. So Paul.
Thanks, Simon. So thank you very much. So it's a pleasure to be back and see a lot of familiar faces in the room. It's nice to be back when your weather is also decent. So. Anyway, so I'm going to start my presentation by just asking the simple question, can we eliminate trachoma as a public health problem by the year 2020? And the reason that year is on there, because that's the year that WHO and all the partners have set aside for that global elimination. Now, frankly, if you would have asked me that question 10 years ago, 20 years ago, I would have basically said, no way, because the amount of work going on at the time was minuscule compared to what the problem was. Now, some of you may recognize the map of Egypt here. In fact, trachoma is one of those diseases that if you can go back in the Chinese literature over 4,000 years, you will find reference to trachoma. In the Ebers Papyrus of Egypt, there's a lot of messaging regarding trachoma. But in terms of Western medicine, it really only came with Napoleon's campaign to Egypt that his soldiers acquired trachoma, and they brought it back to Europe, and then Europe was essentially ravaged by trachoma for many years. It got to be so bad that, in fact, the US, back when the large migration happened from Europe, said that anybody coming into the US had to be examined, and anybody who was found with trachoma was put back on the ship back to where they came from. So it was a quite feared disease, and trachoma was one of the reasons why some hospitals were founded in the US. And in fact, trachoma persisted in the Navajo and Hopi tribes until the 1960s in trachoma. Now, when I look at this picture and I see them everting the lids without gloves or anything, I think we're probably transmitting a bit of trachoma as well, but we won't call them on that right now. It wasn't until the 1950s that a lot of the basic science research was done, and that's when we understood more about the chlamydia trachomatis being the cause of trachoma. And then in the 60s, there was a lot of basic science research that really kind of filled out a lot of our understanding about the clinical disease trachoma. But it really wasn't until the 70s and 80s that we really understood a lot of the transmission pathways. And what we learned was that trachoma was being transmitted physically on the feet of the flies or cloth or whatever from child to child. So the chlamydia was being transmitted physically, and often when I see a picture of a little child with a bunch of flies, that's the first thing I think about. This is probably a trachoma endemic area because it's high levels of transmission going on. The clinical disease, the infection of chlamydia trachomatis, is demonstrated here by what you find if you evert the upper lid and you find these follicles. And not just the follicles, but also a lot of inflammation in the upper eyelid. And a single infection will lead to essentially a self-limiting state of maybe a couple of weeks or maybe even up to a month. But it is self-limiting. These conditions, they will resolve. But it does not confer any immunity. So what happens is these kids get infected and reinfected and reinfected. And in fact, it is that state of reinfection that leads to then the conjunctival scarring you see in this image. And so a single case of having active trachoma does not lead to blindness or scarring or anything. In fact, the estimates are a child must have maybe over 160, 100, 200 episodes of active trachoma before they go on to develop scarring such as this. And if that scarring becomes severe enough, then of course you get the entropion because of the deformation of the upper eyelid. And that entropion leads to trichiasis, and of course trichiasis can lead to corneal scarring. And that's of course what we all are concerned about in trachoma, is preventing that scarring from occurring. So the reason I was always interested in trachoma is because this is one of those unique diseases that affects people throughout their entire livelihood, okay? So the infection that we talk about, that's primarily here in young children, okay? Usually preschool children, they're not in the business of washing their own faces, they don't care about hygiene, so that's where the high infection load is going on. And then those repeat infections will lead to scarring of the eyelid, and generally you see this in people around the age of 20 or so, although I have seen it in children as young as 10. In terms of trichiasis, that often happens in people over the age of 40, and then corneal blindness thereafter. But in terms of infection, when we find disease in communities, you can have up to 40% or 50% of the kids having active trachoma, but the proportion of people with trichiasis may be only 2 in 1,000. So it's not every case that leads to trichiasis. In terms of management, there's what we call the SAFE strategy. The S stands for surgery for the trichiasis, the A for antibiotic treatments for managing the infection, and then the F and E is for facial cleanliness and environmental improvements. And this graph kind of goes back to show what we need to do at what point in time. The one I really want to point out on the antibiotics, what we're not talking about is treating individual cases. This is what we call mass drug administration. So you have to survey a district may be 250,000 people. You survey kids age 5 to 9 years of age, from 1 to 9 years of age. And in that group, if you find that the prevalence of those follicles is over 5%, then you say they need intervention. If it's over 10%, it's 3 years. If it's over 30%, you may be looking at multiple years of mass drug administration. Everybody in those communities in that entire district will be treated for 1 year or 3 years or 5 years. In Ethiopia, some communities have been treated for almost 10 years now. That's a bit of a problem, but we won't go there. The surgery is done not by ophthalmologists. It's all done by ophthalmic clinical officers. 2 different procedures are used, a bilamellar tarsal rotation or a Trabu procedure. There's been a lot of research to understand which one is better, and in fact, we don't really have good evidence one way or the other. The most recent piece of work suggests that it might be Trabu, but there's another study going on right now to confirm that. The programs that are in place are really focused on a lot of case finding, because the problem has been you can say, okay, we have a hospital with a facility doing surgery. That doesn't mean people use it. So we actually do a case finding mechanism where the entire district is covered with people going out looking for cases, house to house case finding. And then those cases then are either brought in or referred in to a particular surgical outreach, and a surgeon will do surgery there, and then follow-up is always then scheduled for either 1 day, for 1 day, 7 to 12, and then 3 to 6 months later. So there's been a huge change in the way we manage trichiasis. We've redesigned the entire training programs, set up supervisory systems, surgical audits. It's become much more professional. And over the last few years, the outcomes from surgery have improved hugely, as well as the efficiency. We don't want a surgeon to go out and do 1 surgery and then come back again. So making sure there's enough patients that they use their time well. So we all knew what to do. We have that SAFE strategy, and that was great. But we were really limited on knowing exactly where to implement. And when I started working in trachoma in the mid-1950s, I was born in the 1950s. In the 1980s, in Egypt, this was the map that we had to go on. Well, that's not really useful in terms of figuring out how many surgeries you need to do and what districts need how long of MDA and everything else. So there was a huge stress on doing mapping. And this started in the year 2012 with support from the British government and US government. And at the beginning of this mapping project, this was the scene that we had around Africa. The light blue are areas in which active trachoma is no longer a public health problem. Red, clearly, are those places that need multiple years of intervention. What we had were a lot of areas, these hashed in areas, which we said we don't know. Okay, so we needed to go in and do additional work. We also had areas like over here in Ethiopia. The surveys were covered too big of a population for us to make any real estimates on numbers of surgeries and what to do. So although that map is better, it is still not good enough to implement. So the project that I was involved with was called the Global Trachoma Mapping Project. Now, this project lasted from 2012 to 16, and over that period of time, over 2 million people were involved in this survey, were examined in 29 countries and over 1,500 districts. This was a huge initiative. Everything was standardized training, standardized exams, quality control. Everything was standardized. All data, whether you were in Eritrea or in Yemen, was all uploaded electronically and all then sent electronically to a data management site. It was incredible. Things happened quickly and things were done accurately. And one of the problems we had in the past was people were grading differently, but we've standardized that now. So it was a huge initiative. Now, that initiative was, in fact, so huge that it has been the largest infectious disease mapping exercise ever completed in the world. And in fact, we're doing a last issue of the journal Ophthalmic Epidemiology, last issue related to the surveys this year. And so a lot of that material has been published, and the last bit of publishing will be done later this year. The nice thing was the mapping also led to really concerted planning, which led to intervention. And that was helped because WHO developed very clear guidelines. Where do we intervene? Where do we not intervene? What do we do? When do we do it? And the planning was done immediately when data was available. And that was critical because, let's face it, donors want to move quickly on things. And the donors put the money on the table to actually implement all aspects of that SAFE strategy in a relatively short period of time. And the nice thing was that data was used was also good evidence for strong program planning. So we had the support of the donors, the ministries were engaged, the non-governmental organizations were engaged. And then the more recent thing is now we have much better definitions of how we reach elimination. And the thing to recognize is that we have moved so far now that when we talk about elimination, WHO is grappling with figuring out how do we make sure that countries know what they need to do in order to reach that elimination and how they have to document it well. Countries, every district in a country that was trachoma endemic has to reach elimination. You can't before a country to reach elimination. So that creates some problems for some countries that maybe have insecure areas. So what is our definition of elimination? So the prevalence of unmanaged trachomatous trichiasis must be less than 0.2% in the adult population. Now, a lot of different pieces to that. Unmanaged, we put that in there because there are people who will refuse surgery. And we're not going to strap people on the table and do surgery on them. It is their choice. And if the program has offered surgery to them and they have refused, that is their decision, and therefore they are managed, okay? They will continue to try to support them getting surgery, but they are not responsible from a public health standpoint for those patients. So it has to be the prevalence of unmanaged trachomatous trichiasis. And secondly, those follicles, it must be less than 5% in that age group 1 to 9 years of age. Both of those criteria must be met for a district to say that they reached elimination. In terms of the surgeries, we've seen a huge increase just in the last few years, essentially a doubling of the number of trichiasis surgeries just in 2 years globally. What we've also seen is the number of people needing surgery is now down to around 3 million people globally. Now, going from what we had over 7 million to 3 million in a few years, a lot of that was because we have better survey data, okay? That's not a reduction just due to doing surgery. So we have better survey data, so there's a new estimate. So I don't want you to think that we've gone from 7 to 3 by doing 4 million surgical cases. No, it's better survey data. In terms of people being treated with antibiotics, again, the numbers have gone up hugely, so that in 2012 it was a little over 40 million people, and now it doubled in, again, those 4 years up to 85 million. So the huge input, and that This is a donated drug from Pfizer, donated azithromycin from Pfizer Pharmaceuticals. So that obviously wouldn't happen if we didn't have those donated drugs. I think what's probably more important is the fact that we have, in the year 2016, 6 million people no longer needed treatment. So although the numbers are going up, we're actually getting more districts in the program, but a lot of districts are graduating, shall we say. And in fact, just last year, this is our Cambodian colleagues. Cambodia is now considered trachoma. Trachoma has been eliminated for the entire country. Cambodia, Laos, Morocco, Ghana, Mexico and Oman, those 6 countries are now completely eliminated. We've not eliminated the countries, no. We've eliminated trachoma from those countries. There are a number of countries like the Gambia, I suspect Iran, China will be next on the list. So it is happening quickly. So going back to my first question, will we eliminate trachoma as a public health problem by the year 2020? Probably not, okay? So we're not going to reach that target, but what I do want you to notice is that we probably will reach that target maybe 3 years later, around 2023 or 2024. So, okay, not right on 2020, but I think that's pretty darn good given the fact that I never expected it to happen for 50 years. So what does it look like today? Again, those are the green areas. This map is from last week. The green areas are those that are now below WHO thresholds for elimination. We still have some areas that need mapping. Well, nobody's going to be mapping in Iraq for the time being, or Afghanistan. We got a lot of mapping done in Yemen, but still it had to stop. So we still have some areas that need mapping still, but the areas that require intervention have really reduced over time. And going back to that map from 2012 to now, you can see that the number of areas that are bright red that require multiple years has really reduced hugely. The number of areas that are green that are now at elimination has increased hugely. So it's been a huge change over the last few years. So I think I'm going to end there and put on one last slide. It has nothing to do with trachoma, but I'm going to put on one slide because of our colleagues from SAVA Canada. I want you to be aware of the fact that SAVA Canada is doing a major initiative over the next year to address the issues of gender and blindness. And I have copies of their little brochure with me here, and Penny Lyons is here. This is an important topic because women still account for the vast majority of blind people in the world, and women have much less access, girls in particular, to eye care. And so what SAVA Canada has done has taken a lot of the work, in fact, that we did here at UBC to identify this problem and then run with it and work with programs around the world to address this problem. So if people want to ask Penny or myself or others afterwards about this project, I'd be happy to address it. But that will be it for now. Thanks.
So we have one question from the WebEx, and anyone from any audience questions from UBC? Yes, Ari.
Just a quick question on the map.
Okay.
Thanks for the presentation. It was very interesting. I noticed that Egypt is not present on your map, and it was, kind of an endemic area at one point. Is that because they're not interested in this project, or they don't have a problem?
Neither one of those is the correct answer. When I got this map from my WHO colleagues, and I do need to acknowledge that they sent me this, I emailed back and I said, we're missing Egypt on here. And they go, yeah, I'm sorry, and I said, fine, I want to get that up there. So Egypt is in a program right now. In fact, they've just started doing 3 different areas in the Nile. It's south from Cairo. So it is in the program. We haven't forgotten Egypt.
Yeah. Thanks, Paul.
You said that once trachoma has been eliminated in an area that it doesn't come back. I'm just not clear on why that would be the case. It would seem that particularly in the areas where it's endemic, I mean, water is going to be more of a problem. The facial cleansing, it's going to be more difficult. Why do you think that it's not going to have a resurgence?
So the philosophy behind the expectation that it won't return is that when we talked about that safe strategy, there were two components. That was facial cleanliness and environmental improvements. Both of those are focused on, obviously keeping kids' faces clean on latrines, so there's minimal fly breeding that then transmits it, and obviously better water utilization. So those activities should maintain a resurgence of disease. So it's not going to be the antibiotic, okay, because the antibiotic has a lifespan. It's going to be the face washing and environmental improvements. In fact, there have been a lot of studies because programs have graduated out of having MDA, having the Zithamax. They've even graduated out of finishing a lot of dedicated face washing and environmental improvement programs, and they have not seen a resurgence of disease. They've gone back and resurveyed. So we have not seen it yet occur in any setting, any meaningful setting. There have been small little blips. There have been little pockets, but it's not been a resurgence of disease.
It's worth being aware that there are places where trachomas disappeared that never had antibiotic treatment, and it disappeared because of those F&E, because environmental changes and facial cleanliness improved. So you don't have to have antibiotics to get rid of it.
Question for Dr. Lewallen from the WebEx. In terms of monitoring for Malaria Retinopathy, how frequent should the patient be examined?
Yeah, well, actually, what we have always found is that at the time the kid's admitted, and by then they're comatose, is when you'll find this. And then you don't see much change over the next few days, sometimes a little bit, but one examination is enough to determine whether or not they have it. It doesn't change all that rapidly. And of course, what we'd love to do is be able to see these kids 2 days before they became comatose, but that's not possible.
I was curious, you pointed to the lack of success in training non-ophthalmologists to do fundus examinations. Given your tremendous success in Southeast Asia in screening for AIDS, signs of CMV and whatnot, how do you account for the difference in lack of success?
I don't guess I can account for it. I mean, those doctors that David Hayden trained to screen for HIV infection, they were doing HIV all the time. That was what they did. And they were really dedicated to learning to do indirect ophthalmoscopy. But that, our experience has just not been good with trying to train. I'm not saying that there aren't a couple of non-ophthalmologists who've learned to do it, because there are a few, but very few. Yeah. It takes a lot of dedication to learn to do indirect. Yeah, you know that.
Just a follow-up question on malarial retinopathy. Does it mean that fundoscopy is a better way to diagnose cerebral malaria than laboratory methods?
I'm not going to say yes to that, because remember there's that group with a normal fundus, okay? And those kids are treated for malaria, and they wake up. They probably have malaria. It's just not severe enough to cause the fundus changes and brain changes, and they need to be treated for malaria. Even if we don't see the retinopathy, we treat for malaria, because it's a small thing to treat for malaria, and it's not something you want to miss. So I would not say it's a better way to diagnose cerebral malaria. I would say in a research project, it's essential if you want to make sure that all the kids fit the case definition and really have cerebral malaria, because you're going to be testing different drugs or studying pathophysiology. Does that make sense? Yeah.
I wonder if you could broaden the discussion on malaria a bit and bring us up to date about advances in elimination of malaria.
I think I can just say no, I can't actually.
Okay.
I know about this one little tiny area of malaria, and that's what I've been talking about today, and I'm no expert on the epidemiology of malaria. Sorry.
And there's another question on trachoma. Can we depend on ocular signs to diagnose trachoma, or should we do a serological testing?
Well, I wouldn't use that word should. In research setting, they are using blood spots to do, to understand if somebody's been infected in the past with chlamydia. For research setting, you can learn a lot by doing various laboratory testing, but to use it as a tool, laboratory testing as a tool to screen populations is not practical, nor is it really going to help us in planning forward. So it's a great research tool, but other than that, I think we're limited to the clinical examination, as imperfect as it is.
And there's another one. How do we minimize the self-report bias during impact survey for trachoma for those who refused as they forgot receiving the information to go for TT surgery?
Say that again?
We want to minimize the self-report bias during impact survey for trachoma, those who refused or forgot to receive the information to go through training. I guess it's a study question, really. Yeah.
Thank you both for your excellent presentations. I was wondering if you could speak to any challenges that you faced with massive drug administration, whether you found that populations were receptive or whether there were other challenges that you faced, and how do you ensure that people are taking the drugs as they should?
Generally, populations have been very receptive. That's an antibiotic, so it has, broad spectrum. So people have generally been receptive to the drug. That said, in some settings, the first time that I tried to do an MDA in Egypt, there, a lot of rumors and, you're trying to sterilize our people and, all sorts of stuff floats around. So you have to be careful and you have to really set up, good systems for communication. And once you do that, then I think that it's generally good acceptance. There have been very few side effects, and those have to be monitored very carefully, and Pfizer wants to get reports back. So those, I think, are monitored actually quite well. But generally speaking, there's been quite easy acceptance of the drug distribution programs. Generally, the older men, maybe they're not around, they don't get it, but that doesn't matter. You really need to hit the children and the moms anyway. So if you miss out on the older men because they don't want to take it, that's fine.
Another question from the WebEx is the retinopathy seen only in cerebral malaria. Does any patient with malaria have a fundoscopy examination?
Yeah, I looked at that question with children with non-cerebral malaria, and you do see occasional hemorrhages in those kids. It's much lower prevalence, but yes, you can sometimes see some of the malarial signs in children who are not comatose.
And
not very often, though.
And a follow-up question, is the retinopathy reversible?
Yes, it is. It's completely reversible, as are the cerebral problems. That's one of the wonders of cerebral malaria is these kids go down really fast, they're comatose, and then they wake up and 2 days later they're walking around apparently normal. So yeah, the retinopathy is reversible and doesn't have any visual sequelae as far as we've been able to determine.
So the retinopathy has great clinical significance then, in your opinion?
The significance is in identifying the disease that they're suffering from, not visual significance later, but in correctly identifying the disease that may kill them.